You're listening to Policy Room by SPRF.
Hello and welcome to another episode of SPRF's Policy Room. Today we have a very special guest with us. His name is Mr. V.R. Raman, who is the head of policy at WaterAid India. He's been leading several important research and advocacy initiatives on issues of water, sanitation, hygiene policy, and programs. Mr. V.R. Raman is also one of the founders of the Public Health Resource Network and the Public Health Resource Society. He is a public health expert with over 25 years of involvement, both on the national and the international levels, in the development sector, with his experience spread across various categories of work and various flagship missions that have come to characterize India's public policy health framework, including the National Nutrition Mission, the National Health Mission, and the Swachh Bharat Mission. Thank you for joining us on this podcast today, Mr. V.R. Raman. It's a pleasure to have you with us.
Thanks. I'm glad to be part of this discussion.
So, just to provide a little context to our audience on the issue that we're going to cover on today's podcast, it's something that has consumed both India and the world for the past year or so, is the issue of the COVID-19 pandemic. And more particularly, with the issues of vaccination. As of today, we have nearly 2 lakh recorded cases per day. The average over the past 7 days or so has been hovering around the 1.7 lakh mark. As of the 12th of April, you had around 900 deaths per day in India. And when it comes to the vaccination situation around the world, we see that just until a couple of days ago, which is again the 12th of April, 1% of the entire world population was fully vaccinated, with around 7% having received at least one dose. On the 8th of April, we see our Union Health Minister, Dr. Harshvardhan, saying that India has around 2.4 crore vaccine doses in stock, with another 1.9 crore being in the pipeline. So, given these figures, Mr. Raman, what do you think is the vaccination situation for India in particular and the world in general?
So let me start with the global situation and then come to India. That may be somewhat better, I think.
Right.
So globally, we know that there are 13 vaccines that has been approved for the emergency use. The 13 vaccines that have been, in different countries, different vaccines have been used. And in India, we know that recently we had 2 vaccines approved for emergency use. One of them initially was approved on a trial basis, and later that was, based on the phase 3 trial data. Now it is also approved for emergency use. And very recently we added the third vaccine, the Russian one, Sputnik. Earlier it was Covishield and Covaxin, and now we have also added Sputnik, and there are more approvals on their way to have more vaccines, to be made available in India. So that is what the situation in terms of the spectrum of the types of vaccines that we have. So that is also going to increase. So globally, I see that there are 860 million people who would have, or 860 million doses of vaccine that have been administered so far, and full vaccinated number of people is 190 million, meaning 19 crore people across the world, which is 2.4% of the global population got the full vaccination, as of yesterday. And when we see to the Indian situation, same, you have already told that we have 190 million doses administered in India so far of these 2 vaccines. The Sputnik vaccine, is yet going to be introduced. So we have 14.9 million fully vaccinated people in the country. The number compared to the global ratio, we are covering close to kind of 10% of the globally fully vaccinated people. You can also say that this is close to 1.1% fully vaccinated people in the country. To put it in the other way, the vaccination in India has a long way to go, and because India and China together form the largest set of populations in the world. So it is very clear that the remaining target in front of us is quite huge, meaning 98.9% of people are yet to be fully vaccinated, wherein 10% of the people so far, close to 10% of people so far, has got the first dose of vaccine. So the first dose to second dose gap that we need to provide. So to reach that, getting that 10% of the people getting the second dose of vaccine and fully vaccinated, it is going to take at least a month and a half or something like that. That is the overall situation. But if we look at the state level, I was reminded about Sania Nishtar, who used to be Pakistan's health minister and also an advisor to WHO. She used to talk about mixed health system syndrome. In India, we have a mixed health system wherein we need to rely on a mix of public, private kind of health system, health service providers. And also similarly, we need to rely on different systems of medicine. That also is not a unified way that we are into. So this gives a very mixed situation. So our overall ability varies from state to state. So since we are a federal country, each state is having different set of capacities or strengths and weaknesses when their health systems and health processes and health service initiatives are concerned. So yesterday, the health minister, health secretary, Mr. Rajesh Bhushan, health secretary of Union Health Secretary of India, was saying that there are states like Kerala, which is doing the vaccination effectively without wasting almost no vaccine units, whereas we have also states wherein 8 to 10% of vaccine units are getting wasted. So if you look at state level situation, there is a varying kind of trend that we see. Varying trend in the sense that Maharashtra, with the highest caseload as of now, wherein vaccination is required. So a high level of vaccination required, only 8,733 people per 1 lakh population is vaccinated in Maharashtra, even for first dose I'm talking. Whereas, there are states like Kerala or Delhi or Chhattisgarh or Rajasthan and Gujarat. Those kinds of states are standing from the 12,000 to 15,000 kind of range per 1 lakh. So this is also one issue. So overall situation, when we are giving a global percentage, we may be at around 10% of the global, or roughly 8% of the global overall vaccination. We need to also realize that this is varying across states. Some states have done excellent and some states are lagging behind. And probably the most needy states are the most lagging behind. These are kind of things that I would say, in terms of a situation analysis, this is how I would like to put it up. And there are a couple of issues about the supplies also, wherein many states are currently reporting huge shortage of vaccine. Whether it is Maharashtra, where the need is high, whether it is some other states, including some of the Uttar Pradesh, districts, were recently reporting huge shortage of vaccination. Kerala is reporting shortage of vaccination. Rajasthan and Haryana. There are several states wherein the vaccine shortage is also being reported, which may be related to the logistics management and also the planning about who will consume more and who will consume less. So the situation is that there is a clear deficit in terms of vaccine stocks in some districts of India. And also there is a kind of trust deficit that was there clearly in the country. That trust deficit slowly and steadily, because of the recent surge of the COVID situation, the trust deficit is slowly getting addressed and people are now going for vaccines. But by the time the demand side is strengthened, the supply side may get a little weakened, because the supply side is entirely into managing the COVID situation now. Not necessarily the vaccination drive will be very effectively moving in the coming few days, wherein we need to look at a lot of curative aspects of the current caseload. So that is one thing. And second, we need to also focus on what you call the supply side of it. There is a major fatigue that is happening of the continuous efforts. So overall, logistically also, and situation where the overall vaccination drive, while the trust deficit is being addressed, although some challenges remain about vaccine resistance or the hesitancy to accept vaccines. The focus that needs to be on the curative side, and also the overall health workforce related issues, because the testing also is something that is quite highly and heavily required at this point in time. So many states and many districts are going beyond their capacities to test people. So testing takes the priority of the districts and states at this point. That also is going to give a toll on the progress of vaccination. So the overall situation is that we have progressed considerably, but there are challenges in front of us.
Some very interesting points that you mentioned there. So I would like to pick on a couple of them moving forward.
Yeah.
Like you'd mentioned, I think it was on the 12th of April that India approved the Sputnik vaccine.
Yeah.
And it was,
Yeah.
I think, on the same day that India became the country with the second highest number of cases in the world.
Exactly.
One of the estimates, I think, by the WHO itself says that, for India to achieve herd immunity, three out of five Indians would have to be vaccinated. And
Exactly. Yeah.
one of the points that you've very clearly mentioned is that despite having made considerable progress, there is still quite a lot of way forward, for us to get there. I think probably to get to around 60%, one of the estimates say we might get there by May 2022. But more importantly, I mean, taking off from these points itself, India, like most of our audience would also know as well, India and South Africa made quite a few detailed statements in particular at the WTO, providing some waiver of the TRIPS agreement on preventing, containment, and the treatment of COVID. And I think it's very important to mention this particular line from the statement, which I'll read verbatim.
Yeah.
Irrespective of the amount of money of any donor country that may throw at the problem, the model of donation and philanthropic expediency cannot solve the fundamental disconnect between monopolistic model it underwrites and the very real desire of developing and least developed countries to produce for themselves. And many people have spoken about this as well. Very interestingly, Mr. Poonawalla also mentioned a couple of these points in a recent interview. So, picking off from this, Mr. Raman, what do you think has been the trajectory for the global community in itself? Because, back when the pandemic started getting noticing, in particular around the 10th and 11th of February, when the WHO got together, it called this emergency meeting, and it came up with two goals for the global research program on COVID. While the first one was obviously how to deal with the COVID-19 pandemic in itself, the second one was it laid emphasis on supporting research priorities on developing sustainable research platforms that would be prepared for the next disease, the next pandemic.
Yes.
Because all
Next
of us know that is coming, either today or tomorrow. So noting this trajectory, one wherein there was optimism about collaboration and the scientific community getting together during the early days of the pandemic, and the situation now wherein there is a clear divide between the global north and the south on international platforms regarding vaccine equity. What do you have to say on these happenings?
So one issue, you started with the India and South Africa joint proposal to the WTO in the October. So this is one of the remarkable movement, which is, you correctly said that it's one of the remarkable movement wherein the proposal called for a suspension of the IPR rules and other obstructions for sharing of the know-how, especially to various developing countries, to enable them to kind of manufacture various vaccines, medicines, and other medical products. So, to more rapidly bring the COVID-19 pandemic under control was kind of aim of that movement. But, we need to note this in a regrettable way that the global north, specifically US, UK, and European Union, they blocked this proposal. But, one of the things that we would have global, community of the third world is not the right word at this point in time, but we can say that the lower middle income countries or the developing and underdeveloped countries, the expectation from India is little more high. We would have expected that as a country we pursued this further, press this further, and push the what you call the north of the world to accept the rights of the global South and also the countries, low income countries, lower middle income countries. Those groups were requiring some kind of strong position from India, but that was not really coming up. So I think our government even now it should strongly take this position so that we are able to benefit the most needy populations in the world. So this is one issue. And second, recently there was a meeting India participated. This was about the Indo-Pacific Quad grouping, wherein US, Australia, Japan, and India were there. And the meeting discussed enhancing the vaccine supplies, mainly for the Indo-Pacific region, through an agreement under which the US would provide the vaccine know-how and share financing with Japan. India would take responsibility for manufacture, and Australia would handle the logistics for supply for about 1,000 million doses to the region by end of 2022. But here we need to see that this issue was a strategic partnership. What is India's role in this when four countries were discussing this? How to kind of strengthen India's role in this process, being one of the very key contributor in terms of manufacturing various vaccines. So how to take a position and not to agree the unilateral positions of some of the countries, but go into a bilateral relationship. These are issues that I think we could have little more focused upon. So I think this particular issue of good track record that we are having of assisting global vaccination efforts, but we need to push back on some of the agenda that is pushed by the high income countries. Then that is where this vaccine inequality issues that I wanted to discuss. We will come to that a little later. I think India can play a very critical role by way of standing between the powerful nations and the low access populations, and ensure access to vaccines and also escape from the pandemic, including the future pandemics, as you said, by way of supporting research in a meaningful manner, production in a meaningful manner, and also deciding on various logistics and the know-how provision. All that I think we can do much better than what we are doing as of now.
Those were some really interesting points that you mentioned about how India, it has taken the right stand, but it ought to push a little harder on these global platforms. But at the same time, what we also see coming from many of these WTO member nations is they question us. They question the global South as to what is the manufacturing capability of countries in the global South. And this is a stance that is taken by many. So do you have anything to say on this front?
See, if you look at the current situation of how India is handling, historically, our research and development over the last, I could say that from independence onwards, we have been setting up various institutions that can handle, we had public sector units that could have handled many important kind of production when it comes to vaccines. We have now a huge number of, if you take an example of the HIV antiretroviral medicines that was produced in India, and which is actually some of the very specific initiatives that has helped the global South in terms of achieving self-reliance in terms of, and also cheaper and reliable kind of medicines. They are coming from countries like India. So this is something to be noted. And of course, China is also one other important manufacturer in the same region. That is something to be noted as well. But we need to clearly see this fact that India is able to supply vaccines to 86 countries at this point in time. And many of the global, that is also, when the criticism on the global South is coming, we need to also see the fact that many of the global tycoons are reaching out to Indian producers, whether they are private producers for sure, whether it is Bharat Biotech, whether it is Reddy, whether it is Serum Institute, whether it is other kind of factors in this sector also. These are the names known to people because of the recent vaccine development, but there are many other actors and players in this entire segment. So to say that the production capacity is lesser itself is something that, and this argument of ridiculing the capacities of global South is a general tendency that we see. These are part of the global diplomacy as well. So I don't want to comment on that part of it, but Definitely, I would like to emphasize that the capacities of India or capacities of global South, we have several countries now, India and South Africa join hands on this issue. So we have the production capacity or quality control capacity, supply logistics capacity. I don't think these are lacking. But the thing is that how these things are controlled, how these things are regulated, the global environment towards that is balanced to is inclined towards the most powerful countries, wherein countries like India used to take a stronger position before, but over the last 20 or 30 years there is a difference. After the WTO agreement, we can see that the IPR and various other things that was introduced as part of the WTO, we can see that there is a major decline in the resistance that the global south or the lower and middle income countries or these segments are able to put up. So I think that is where the crux is. So if we are able to speak up properly, putting up facts and figures of how this side of the world is able to actually serve the other side of the world on various intellectual aspects, I think that kind of a presentation is missing. That is where the kind of doubts expressed by the powerful are going unanswered. I think we need to learn how to answer this without jeopardizing the balance of relations and all that. But how to do that is something within the current policy framework that our country and various other countries are adopting towards the powerful nations. So they need to find a balance and fine tune their positions about this. This is how I would see. It's not about a production capacity; it is about the diplomacy.
I'm going to pick off on one very particular point that you mentioned, and this is just to digress a little from the main point of our
Yeah.
discussion here. You mentioned the issue of the HIV pandemic and the drugs therein. So this reminds me really of the situation in 97 where the Mandela government really mandated the production of drugs which were being produced in the Western countries for over $10,000 a dose. And in response, you see that a huge number of these drug MNCs filed a suit against South Africa alleging violation of the TRIPS agreement. And really connecting that to the issue in the present, wherein you see the whole issue of intellectual property being sort of given a precedence over issues of accessibility. And this has been a long standing agenda being pushed by quote unquote big pharma. And now you have recent, I wouldn't say recent, but you have players like the Bill Gates and the Melinda Gates Foundation. So where do you see the role of such institutions in sort of perpetuating a structure wherein accessibility is more of an exception rather than the norm?
See, this is really, as you rightly told, this is a digression from what we are discussing, but it's an important and interesting point. So, if you look at the global institutional structures that has been introduced on many of these things, whether it is Gavi or the philanthropic organizations, I'm not going to name all of them because naming one may not be sufficient. There are many, but of course, the most powerful will be named, and you have already done that. So how this institution functions also depends upon where are the resources for these organizations are coming from. So that is where the accessibility versus power comes in. The accessibility agenda is quite often not discussed at all. So 97 South African incident that you told, and also the Indian, some of the very specific initiatives from India for ensuring access to the most vulnerable communities and most affected communities, they were quite significant. And the global institutions, while and the global processes and regulatory frameworks, while the stated objective is about achieving equality, equity, and all that, we all know that how they are benefiting or they are focusing mostly for the powerful and the whether they are the big pharma, whether they are the other profiteering kind of agencies. So the play of global capital is including the changing forms of capital. I'm not just talking about money here. The changing forms of capital also, the global institutions are inclined towards making the powerful more powerful rather than enhancing the access to the most need. I would limit my response to this.
Thank you so much, sir. And when we speak about issues of access to vaccination, not just to vaccination, but quality healthcare in general, when we speak
Yeah.
about India, it is evident that the issue really interplays with factors of caste, class, gender, etc. And this is something that you and WaterAid have worked on quite a lot. In particular, I think you've come out with a study as well, health, safety, and social security challenges of sanitation workers during the COVID-19 pandemic in India. And
Yeah.
when I was going through the report, some very interesting figures that stood out to me is that, obviously in India, when we speak about health sanitation workers in particular, it is dominated by citizens from particular social locations. And
Yes.
despite having high levels of awareness on the need to be protected against the COVID-19 pandemic and regarding symptoms of the disease, very few were actually given the kind of protection that was required, given the fact that they really are at the front line of this war against the pandemic. So, could you give us a little insight into the kind of details that really struck you in the course of this study?
Okay. So I'll take you to beyond the study, because that study was done a year before, and currently those issues have even further gone up, and the challenges are even higher now. So one issue, particularly the most kind of excluded social groups or the most marginalized social groups are facing. So these are related to the equality discussion that I was pointing. Uh, when the most challenging share of work is allocated to a particular group of people, whether it is when it comes to a hospital, for example, in that hospital, there are several sets of people who are into the front line of looking at the COVID pandemic and COVID patients, direct kind of service to the patients. So that include, so whenever we call human resources for health, so the list of human resources for health somehow, uh, they are very important. I'm not saying they are not important. They're extremely important. Without them, it will not function. But we are not able to count beyond doctors and nurses. So even within health sector, there is a problem of this allied health professionals are not counted is a major issue that they see. So allied health professionals include lab technicians to a various set of people who are providing various types of services to people, which are not necessarily counted within the broader framework of caring people or prescribing medicine to people or providing medical care to people. So beyond that, there is a set of people. But even within the allied health professionals, we don't see the people who are cleaning the hospital premises, collecting the waste from the hospital premises, and all the hazardous kind of things, who are kind of taking the pain of removing all the various hazards from a hospital. Those kinds of things are not really looked at. I'm talking this from the health sector point of view. So when it comes to sanitation, India is one of the countries wherein sanitation is not seen from a public health perspective. So broadly, globally, even in many of the African countries, the sanitation and water related issues are looked after by the health departments. So they have health services and also the public health and the preventive health. They have several sections within the health department, and one of them is handling the water sanitation kind of a thing. But in India, we are seeing it little compartmentalized, and that is part of the either a ministry for drinking water and sanitation, or part of rural development, or part of some other. So the importance of seeing it from a health perspective is generally missing. That also leads to the marginalization of the sanitation workers in the country. So if you see the sanitation workers currently, are they getting, because if you see, isolation is now one of the problem that we are facing extensively. We don't have beds available for COVID patients in hospitals. So what is the advice? The advice is that most of the people who don't need hospitalized care should be isolated at home. Then when they are isolated at home, the daily waste and other things are collected by the sanitation workers, the domestic waste pickers, one category of the sanitation workers. Uh, and then at the hospitals, the waste is collected by the hospital cleaning staff, the sanitation workers over there. Biomedical waste is treated by a set of people. The waste treatment plants in the hospital, biomedical waste treatment plants in the hospital are run by a set of sanitation workers. And the sewer lines, one of the important findings about COVID is that the COVID-19 virus has been extensively seen in the fecal matter, human fecal matter, and sewer lines are carrying this fecal matter to the centralized treatment plants, and the sewer lines are regularly being repaired by a set of sewer cleaners or sanitation workers. Septic tanks are, even in our country, broadly, manually cleaned by a set of sanitation workers. And there are still existing the habit of or the practice of manual cleaning of the dry and insanitary latrines are prevailing in some cities, and the manual cleaning of the human feces by bare hands and carrying the feces and putting it, disposing it somewhere, that is happening. So this segment of sanitation workers, a large segment of sanitation workers, are heavily affected by the COVID. Has added risks to their lives. Already they were in risk, their lives and their dignity, because of, you already told that they are coming from a specific caste and specific community, and also these works, especially, they are not paid well, and also they are not respected well. So they are in a income deficit, and they are staying, of course, in a very crowded slum, in an informal settlement, without having their own houses, and they are not natives of the cities that they are living. So they are living in a very minimum kind of facility, wherein they need to pay only or spend only a little of their income so that they can spend for other things. So this overall challenges of sanitation workers is quite heavy. So one of the inequalities that I am seeing in this COVID era, we are talking about vaccination. So I'll take it back to the vaccination. We don't even have how many. You would have seen that some 15 days before, there was an order from the health ministry saying that the frontline workers vaccination is being misused by various private facilities in a way that particular category is used for giving vaccines to some specific people, favoring some specific people, so that particular category's vaccination has been stopped. But have you thought about who is missing out as part of such stopping of such vaccination? Quite often they are the kind of sanitation workers and the kind of frontline workers are missing. The hospital staff who are having access to the vaccination processes, they will cover. But those who are outside the hospitals, those who are outside the facilities, they are really struggling for getting themselves protected before they go in front of the people, in front of the infected persons, before cleaning the waste produced by the infected persons, and those who are managing the dead bodies. That is also one set of sanitation workers. So this is a very strange kind of equation that is in front of us. We don't even have data of the most vulnerable community that is handling the most risky kind of challenges in terms of whether it is pandemic or whether it is daily life. So how can we have a clear monitoring of those all vulnerable populations are protected completely, and the society, the health systems and the government and all individuals who are deploying these people are doing justice to such workers? It's a major question that is continuing to be unanswered.
In these points that you mentioned, that really illustrate the forced and perhaps purposive sort of invisibilization of India's
Exactly.
sanitation workers. One thing that stood out quite starkly for me is that increasingly a majority of India's sanitation workers are in the informal sector, with scarcely any job security, any social security. And one thing that is very evident from the study and from your discussion as well is that there is an immediate and urgent need for structural transformation in India's health policy framework.
Exactly.
And this is another point that you mentioned is, the very drastic crumbling of India's health infrastructure. The lack of beds is alarming. It's on the news every day. And like you mentioned, this study was done some time ago, perhaps more to the beginning of the pandemic.
Yeah, it was June 2020.
Right. So do you see any change, any positive change, anything optimistic in terms of structural transformation that could better prepare us for whatever might come next?
Are you asking about the sanitation worker regime?
the sanitation worker regime in particular, but also India's healthcare infrastructure on the whole?
The sanitation worker regime, uh, if you look at the political intent, the what you call realization that we need to do justice to this specific set of people is there. I mean, that is very much there. If you see that various statements, our acts, our policies, our programmatic frameworks, our budget allocations, all that says that there is a thinking about the most vulnerable communities. As example, I'm using sanitation workers here. But the problem is about how we are actually institutionalizing the implementation of those intents. So the political will, as a governance student, I'll see political will as a mix of, I mean, everyone should see that as a mix of intent and action. So what we are having is the intent. The action part quite often we are missing. But recently I can say that this safety and security of sanitation workers, thanks to some of the efforts put in by us, and joining hands with the World Health Organization, and the World Bank was part of it, International Labour Organization was part of it. So when these voices came together, so there is some kind of realization that is happening. And also in India there has been some realization that we need to do something, but how part often is missing in our discourse, I understand. In Orissa, I could see that the state government of Orissa wanted to, identify sanitation workers into skilled worker category and to enhance their professional recognition and all that. So they have core sanitation workers, one category defined, and put people into that, and another level 2 core sanitation workers they have defined, and the daily wages and various other things have been defined for them, and the enumeration of these people have started. But on the other hand, in the same places we can also see that the safety and security of sanitation workers and their families, we are yet to understand what it is, what does it mean. While we are our salary, the mainstream persons who are into salaried income and all that, whether when they are very vocal about their salaries, their emoluments, their incomes, their rights and all that, the same formula we are not able to apply when it comes to the most vulnerable kind of workers. So that is where, even yesterday I could see that two of the sanitation workers died in between cleaning the septic tanks, the sewer lines in one of the Indian towns. So this is continuously happening. So the apathy, the systemic apathy needs to be corrected, and we need to really, really find ways for introducing some accountability, some responsibility of various individuals who are running the machineries. Those kinds of things are lacking. And also we need to promote honestly stating the situation of, for example, these workers. So what kind of incentive can you give to an officer who is talking truth about the bad situation of a group called sanitation workers? Similarly, what kind of a disincentive or a punitive measure you can introduce for those people who are actually suppressing the causes and the needs and the rights of this specific group? We have to think slightly differently. In our guidelines, are we monitoring whether all these workers, all these vulnerable categories of workers have been covered or not covered? So before we stop the enumeration and the vaccination of frontline workers, have we looked at whether all our ASHAs have been covered or not, who are actually running from post to pillar for ensuring the care of the people who are the COVID affected? Similarly, have we looked at our sanitation workers? Have we looked at our field force? Have we looked at those who are into awareness drive in villages? So we need to see with some kind of sensitivity, with some kind of realization that without actually attending and addressing the problems of these frontline workers, merely looking at those privileged classes of workers is not going to solve the problem.
So coming more generally to India's healthcare infrastructure on the whole, like I had mentioned earlier, the complete lack of empathy from this is, it's not, I don't think it's a matter of opinion as much as we have seen this in the news quite a bit. The lack of empathy from a number of private healthcare providers, the lack of beds, the complete crumbling of India's healthcare infrastructure. Well, going forward, how do you think this can be really rectified? Is the system far too broken for there to be any sort of meaningful course correction?
Okay. I think this needs to be seen from both sides of the health system side also the people side. Otherwise, we can miss the actual. We cannot blame all the time the individuals who are working part of the system for the structural gaps. The structural gaps are sometimes also because of, for example, Kerala is able to, with recently there was a hike in the number and all that, but it is able to manage its problems in a much commendable and better way compared to the other states because of the approach of the system and the structure of the system is better placed in that state of India compared to many other states. Similarly, Tamil Nadu also within its minimum resources, they are able to produce better results. So we need to see that this apathy, where is it coming from? If the states are not investing into proper systems, the available workforce are left only with a choice of performing suboptimally. So the system is made for suboptimal performance is the major problem that we are facing. That is where I started with this mixed health system syndrome. So the mixed health syndrome is something like that. We really don't have the various systemic requirements met. So we are looking at incremental enhancement of human resources. We are looking at incremental enhancement of their placements and various other kind of requirements. And then we are expecting when the staff requirement or infrastructure requirement or facility requirement or financing requirement are unmet, we are expecting the available services to perform in a world-class fashion and to deliver. So first of all, we need to understand that why many of them, because of their class character, because of their orientation, they are having apathy to the poor. So there is a segment of workers in the health systems who are really apathetic to the poor. They don't have that empathy that is needed. They don't show their commitment to the duties. That is one privileged class in all our services, including health services. I'm not talking about them. But there are people who passed the examinations and with commitment went into doing their duties also. And that is a considerable segment actually. But why are they becoming part of this apathetic systemic approach is something that we need to understand deeply, I think. So the approach of our governance is not creating the possibility of performing well, performing optimally is an issue. So we can call it as an operational constraint or an institutional constraint. So unless and until we develop our institutions in an optimal manner, these issues are going to continue. For example, we can see that from the vaccination, again, I'm going back to that vaccination discussion. If you look at the cold chain systems that is available in some of the North Indian states and the similar kind of systems in some of the South Indian states. So how, with the similar resources available for all states of India, some states are able to invest well and some states are not able to invest well? And why some of the capacities in some of the states and educational quality in some of the states are better compared to the poor quality of education, poor quality of capacity building and training and poor quality of service orientation and motivation and commitment in some other states. So there are issues to understand, unpack, and then address in many of these things. I think then only we can actually look at the issue of how we are dealing with people with some element of respect, empathy, and some kind of commitment to what we are doing. And many of our public facilities are overcrowded. This is a fact. So unless and until we are going for a ratio according to our kind of population, what is the kind of facility that is needed for serving the large segment of population? If the service providers are put into, with minimum resources, if they are expected to deliver maximum, that can lead into some problems. So we need to understand and address some of these core issues, and we need to invest much better in health. So we are currently investing much less than what is required. 1.25 of our GDP is going into health as per the current situation. The National Health Policy in 2016 told that it will go up to say 2.5% of the GDP will be committed. But if you look at the incremental growth of that, from 1.2, we have not gone much. So even if you are talking about achieving the policy in 2030, in the current way, we are not going to achieve it. So unless the investment in health and the spending capacities in health and the broader resources that is put in for health, including human resources, is enhanced, this problem of apathy is one of the byproducts of that. provided, I already told that, there are some privileged, groups within the health service providers who are already apathetic because of their, class and caste and various other characters, economic characters and all that.
Thank you so much for your remarks, Mr. Raman. It has been a pleasure and very educational for me personally having you on our podcast. I hope it's been educational for our audience as well. For your remarks on vaccine nationalism, vaccine equity, and for more importantly, pointing out the issues that characterize the Indian healthcare system and the global healthcare infrastructure on the whole, pointing out the need for a radical transformation in the many of the structures that are already in place. It has been fantastic having you with us this evening today.
Thank you. To conclude, I would say that currently we need to look at vaccine inequalities from all these, from the infrastructure perspective, from the what kind of population is not getting these services, that kind of a perspective. Unless and until we focus on the most deprived communities and classes of the society, not only in vaccine, across various sector and system priorities, and also outside health sector, we are not going to achieve what we are expected to and supposed to achieve. So we need to realize this and work towards addressing these inequalities. Thank you.
Thank you so much, sir.
Thank you for tuning into another episode of Policy Room, produced by the Social and Political Research Foundation. SPRF is a youth-oriented public policy think tank based in New Delhi, working to spark dialogues for a better democracy. Stay tuned for more episodes coming soon.